Welcome to the GE Healthcare webinar, Provider Strategies for Success with the Economic Stimulus Package conference call. During the presentation, all participants will be in a listen-only mode. Afterwards, we will conduct a question and answer session. At that time, if you have a question, please press the 1 followed by the 4 on your telephone. If at any time during the conference you need to reach an operator, please press star 0. I would now like to turn the conference over to Russ Browder, Marketing Manager for GE Healthcare. Please go ahead, sir.
Good afternoon, everyone. My name is Russ Browder, and I am a Marketing Manager at GE Healthcare. I will be in a new series from GE focusing on the recently passed $31.2 billion healthcare IT stimulus package, also known as the High-Tech Act, and we'll be talking about what it means to provider organizations. Today's session is titled Provider Strategies for Success with the Economic Stimulus Package. We have an interesting program for you today and 2 great speakers. With us today, we have Elizabeth Woodcock, founder of Atlanta-based Woodcock & Associates. The author of 7 best-selling books, Elizabeth is a speaker and trainer. She's passionate about helping physicians and administrators improve practice operations and revenue cycle management. A fellow in the American College of Medical Practice Executives and a certified professional coder, Elizabeth received her Bachelor of Arts from Duke University and her Master of Business Administration from the Wharton School of Business, Vice President and General Manager at GE Healthcare IT. Jeff will share new approaches and solutions available now for providers looking to accelerate their adoption of key new technology in response to the stimulus from Washington. I'd like to welcome our speakers and all of you to today's session. As I mentioned earlier, our topic today is the High-Tech Act for Healthcare, and today we will provide new industry perspective on what providers should be thinking about as they analyze the High-Tech Act for Healthcare and plan what to do from a technology standpoint. For our agenda today, we will start with Elizabeth Woodcock. She will provide a brief overview of the High-Tech Act for Healthcare, and will then explore how providers can prepare to benefit from the new incentives for technology adoption, including what kind of additional information to look for, next steps to consider now, and the importance of context, the need to keep an eye on the bigger testing solutions available now from GE. And we will then close with an interactive question and answer session. I would also like to mention that a recording and copy of today's presentation will be made available. After today's presentation, it is our hope that you will be better equipped to keep alert on new developments in the legislation, understand what steps make sense for you now, and learn the essentials of identifying the right partner, and understand how these recent developments fit into a longer-term healthcare information technology plan. So with that, I'm going to turn the session over to Elizabeth Woodcock. Elizabeth, please take it away.
Thank you so much, Russ, and thank you to everyone for joining us today to talk about the Economic Stimulus Package, Provider Strategies for Success. Former United States President George W. Bush and current President Barack Obama certainly don't have much in medical records. Indeed, Bush proclaimed in his State of the Union address midway through his second term that every American have an electronic health record by 2014. And it appears that through the economic stimulus package, and in particular the High-Tech Act, that Obama is making good on that promise. The American Recovery and Reinvestment Act of 2009, which was passed back in February, just about 60 days ago, is the subject of today's webinar. The act is fondly known as the Economic Stimulus Package, and for our industry, the healthcare industry, that is called the High-Tech Act. To discover how it impacts you and your practice, let's get started by reviewing the agenda. Our agenda today, Tech Act. Then we're going to talk about your next steps. And very important, let's review the value proposition, why technology can be a positive return on investment. And then we're going to talk about the challenge that we have on hand in terms of reimbursement in the year to come. So let's go ahead and get started. I mentioned the American Recovery and Reinvestment Act of 2009. And in particular, what we're looking at is Title 13, the Health Information Technology. Now, we have given you, as you will note, the URL, and I would encourage you to go ahead and read the Act itself. It's a little bit lengthy, but it's well worth a good 30 minutes of your time. And what you want to do is start on page 114, the section, and then you also want to take a look on the section that begins on page 353. Essentially what it's telling us, physicians will be reimbursed for up to $64,000 for demonstrating use of a qualified electronic health record in a meaningful manner. Now we're going to talk about those two important words, qualified and meaningful, and what the federal government is telling us that we need to do to be qualified and meaningful. We're going to get this money over a 5-year period. And I got to tell you, perhaps even bigger news is that there are actually going to be penalties. Remember, George W. Bush said 2014, and Barack Obama's embracing that. And so if we haven't gotten that EHR for our patients, penalties for not adopting actually begin in the year 2015. And that's a pretty big step, qualified. What do we know? The Act specifically tells us that qualified, which really refers to the system, okay, not how you use it, but the system itself, it has to include patient demographic and clinical health information. It doesn't give us a lot more information about that, but we presume it's basic health information, a current medication list, your office visits, test results, et cetera, and importantly, a qualified electronic health record has the capacity to, let's review these 4 items, provide clinical decision support, support physician order entry, capture and query information relevant to healthcare quality, and exchange electronic health information with, and very important, so we do know those, we don't know a lot of details, however. Now, the Act does specify that a new office of the National Coordinator for Health Information Technology is going to be established. And what we are expecting, of course, to hear is what exactly systems are going to be, quote-unquote, qualified for this Act and, of course, getting this money. Now, let's turn to the term meaningful use on slide number 9. Meaningful use. So we talked about the system itself, and now what we want to speak to is the actual use of it. And how do we be a meaningful user? What we do know is that your system must have electronic prescribing, and you must use it. So electronically exchange health information. And then finally, as a meaningful user, you must submit information on selected clinical quality measures. Okay, we do know these are straight from the Act. Now, we don't know, however, how are you going to explain? How are you going to prove? Are you going to have a G code, a CPT code that you put on your claim that says, yes, you're prescribing, yes, you're going to electronic exchange health and etc. We don't know that yet. So the specifics regarding this quote-unquote meaningful use as well as how to report it are to be determined. They're to be determined. So again, we heard about qualified, the system itself, and now we know the term meaningful in terms of how your practice will actually make use of the system in order to achieve these funds. Now let's talk about the funds. On the next slide, what we can see is a chart. In order to get, on slide number 10, in order to get the maximum amount of funding, $44,000, we've got to start 2010. January 1st, 2010, we've got to be ready to go, and we're going to capture that largest annual bonus there, $18,000, $12,000, $8,000, $4,000, $2,000, adding up to $44,000 if we install by 2011. So that is really, really key to recognize. To capture the full amount, we've got to be ready by the beginning of that year. Now, you may note, oh my gosh, Elizabeth, you described 64. Now, I will tell you that there is up to that additional, it's approximately $20,000 additional for high-volume Medicaid providers. So what's interesting is this act is actually tying dollars to Medicare as well as Medicaid. And so for those of you who are high-volume Medicaid providers, depending on the funding that would come through your state Medicaid administration, you may get these additional dollars, again, up to $64,000. So we do know there's a lot of money on the table. Again, we do know that you have to have a qualified electronic health record, and you making full use of it, but the details are pretty sketchy as of yet. So let's go ahead and talk, because I mentioned at the beginning, I think one of the challenges that we have is if we say, no, we're not going to take advantage of this funding, there may be a reason for it. You may not want to embrace an electronic health record. The physicians may not want to. You may not have the capital in order to do it. But if you don't, we are going to see some penalties coming through for not adopting. Now, these are penalties that are going to be paid through Medicare reimbursement. So we're not going to, for example, have the IRS involved taking penalties off of your tax returns, but you will not see the full Medicare allowable as of 2015 if you do not have a qualified electronic health record and are making meaningful use out of it. Beginning in 2015, Medicare or allowable will be 1% less, or 99% of the allowable. 2016, 2% less, 98% allowable, 3% in 2017, and beyond 2017, the Act does indicate there will be additional penalties. However, they will not exceed 5%. So let's say you are absolutely bound and determined technology will not enter your practice. Just know that's really the floor. You're not going to get less than 95% of the allowable as of 2018 and beyond. Now, there will be some exceptions. The Act very clearly states that. There will be some exceptions made on a case-by-case basis. And these are being outlined for quote-unquote significant hardships. And the Act does specify without sufficient Internet access. So again, we do know that this is really a carrot and stick approach. There'll be a carrot out there until 2016. There'll be a carrot out there ready for you to grab 2015, but once you get 2015, we are going to see that stick. We are going to get some penalties for those years, again, up to a 5% reduction of your Medicare allowable. Now, there are some questions outstanding, and if I may just review those quickly on page number 12. These are what we do know. There's a lot of questions, but we do know these facts. We do know that if your practice is under a single tax ID number, you get an electronic technology, wants to get the electronic health record, but nobody else does. What we do know is the practice is not going to receive all of this money for each one of its doctors, if only one is a meaningful user. Okay, so we cannot go into this and say, oh, well, you know, Dr. Smith, he loves technology. He'll be our representative, and we'll send the claims or whatever we need to do, and all of our doctors will get this money. We do know that you cannot just have one physician and everybody will have access to this money. We also do know, for those of you who are early adopters, because you're sitting there saying, well, gosh, Elizabeth, I already have an electronic health record. I'm one of the, depending on the survey, 15 to 20% of the practices in the country really good at it. We do know that you will qualify. We don't know the specifics of how you will prove that you will qualify. We don't know that yet, but we do know that you will qualify for this bonus money. What we do know as well is that MIPA, which is sort of our new HIPAA, MIPA, which is the Medicare Improvements for Patients and Providers Act of 2018, that is the act that gave us that 2% of allowables for e-prescribing. So right now, many of you participating in that e-prescribing benefit, we do know that we can't expect next year to get, oh gosh, we're going to get the 2%, and once we start getting these dollars in the door in 2011, we won't be eligible for both of those dollars. Now, we also do know that for those of you who practice in a HIPSA, and a HIPSA is a health professional shortage area, that an additional 10% is going to be available for you. I think this is really good news, because for those of you, again, really critical access problems in a rural area, or even in some HIPSAs are in an urban area, but where there is a shortage of health professionals, we do know that you are going to get a little bit more money than the rest of physicians. So those are the facts, but there are a lot of questions. On page number 13, the biggest question is, okay, this all sounds well and good, $64,000, up to $64,000 for each one of my doctors, Elizabeth, and we're all asking, how do we get the money? But we need the answers to a few things first. What is certified? What exactly is certified? I mean, which systems are certified? We don't know that yet. We do know that there is something called the CCHIT that's been around for a number of years now, and it is the Certification Commission for Healthcare Information Technology. Again, the CCHIT. Now, we do not know if this private, nonprofit organization that is indeed endorsed by the federal government, will they be the ones that will set the standards of certified, of qualified electronic health record? We don't know. Will it be CCHIT? Will it CHIT? Will it be a whole nother accreditation body? Most folks agree that it is going to be CCHIT, but we have not heard that yet. Now, the second question is, what is meaningful? Now, we do know the bullet points that I read from the previous slide, what we do know about meaningful use, which is, remember, that e-prescribing and so forth. We do know those very vague terms, but we don't know the details. And most importantly, we don't know how to prove it. So you're working in a practice in Omaha, Nebraska, and you're a meaningful user. How are we going to get that information to Medicare, to the federal government, in order for them to release these funds to you? That is a question that still remains in our minds. Now, of course, what we do know is that historically, when it comes to PQRI, when it becomes to the MIPA e-prescribing bonus, that the way you have proven use of the technology, proven use of meeting those quality measures in the case of PQRI, is to use specific procedure codes as defined by CMS on your claim forms. So again, just like we intuitively believe CCHIT will be the certification body, we intuitively believe there'll be some way to report this stuff on your claim forms. How are you going to apply? If you've already implemented an electronic medical record, a big question is, how do I access this money? And then, of course, how's the money going to be distributed? Is it going to be distributed on, checks that are cut once a year? We don't know the answers to those questions. So we do have a lot of questions that we're really, really looking forward to this new Office of Healthcare Information Technology in order to tell us. Now, what are your next steps? What I would strongly suggest is, if you are one of the 85% of practices that does not have an electronic health record, it's time to go ahead and develop a request for proposal and identify a vendor. It really is time. However, there are several key areas to keep in mind, because I got to tell you, I think right now we're very blinded because saying, oh my gosh, $64,000. I got to get and run out and get me one of the systems now. But we got to remember, really is a huge change to our practice. It impacts our revenue cycle. And we've got to keep this at the top of our mind, because many practices, they set up the task force and let's go get the EHR, and you know what, they forget that, the electronic health record, the charges, for example, flow over to the practice management system. And what if that interface is broken? What if it doesn't work? What if it's not picking up the 5th digit of an ICD-9 code, et cetera, et cetera? If it doesn't work, you're talking about massive cash flow problems. So please don't eliminate your business office, the revenue cycle, in discussions of choosing a system. You really need to, at least in my opinion, look for a full-scale, true electronic health record, because we want to qualify for this awesome bonus, but we are making sure that we are embracing not just the clinical side, but the administrative side of our practice as well. We also have to remember, I think, this really key area, that a physician's time is really the most important asset of our medical practice. Why is that? Because it's what we can bill for, and most importantly, it is what our patients want. And so if I have a physician and you put in an electronic medical record and he or she is spending 20 minutes trying to type on the computer and getting documentation done, we have not preserved the physician's time for a billable activity, for rendering quality medical care to patients who want his or her time. We've got to keep that at the top of our mind. How are we going to integrate the system within our workflow, and or how are we going to change the physician's workflow so that the electronic health record doesn't hinder his or her time? We need to really put a star by that one, because it's very, very critical. And for those of you who say, well, gosh, it'll only be 6 or 12 months when it's hindering his or her time, no, we can't afford to do that. We can't afford to do that. Cost savings. Now, there is going to be a cost savings with an electronic health record if you're able to truly, truly embrace technology and automating your workflow. If you are still running your paper processes with an electronic health record, practice more dysfunctional, and it ain't going to save you a dime. So we really need to keep in mind these 3 important things and really determine a return on investment, an ROI, for your practice, okay? Don't let anybody else do it for you, because everybody's going to say, oh, it's wonderful, it's positive, you make so much money. You've got to do it for you. So let's talk on slide 15 about the value proposition. I truly believe that this is a nice carrot from the federal government in terms of financing an electronic health record, and it really, really is something that your practice should take advantage of. But in addition to that, an electronic health record can give you patient safety. It really can. It's not going to give you 100%. It's not going to guarantee patient safety. But the beauty, and he or she is meeting a patient who has been admitted to the emergency room, is in the ER, and doesn't have any access to the record, may not understand or recall because the patient is one of 2,000 patients he sees about a critical piece of information, whether it's medications, whether it's something that happened the last office visit, et cetera, et cetera. Now he or she has access to the patient's record, really instantaneously. 3 o'clock in the morning, they have access. And I think patient safety is really important, and certainly is what an electronic health record can help us. Doesn't guarantee, but can help us deliver. Pay-for-performance programs. We do know there are a number of pay-for-performance programs, of course, from Medicare, PQRI, as well as many of our commercial payers, and electronic health records can really help facilitate us doing that, participating in those, and really capturing, ideally, the funding that's available from those, as well as doing what's right for the patient. Contracting with commercial payers, saying I have an electronic health record really can give you a leg up with commercial payers, but I think it really allows you to take the next step. You know you provide great quality medical care, but with a paper record system, it's hard to prove that to a commercial payer. What do we say? Oh, let me share with you some photocopies of some notes from patients. Right? I mean, you can't do that. So an electronic health record really allows you to say, for your beneficiaries, insurance company, this is what we're doing for them. Look at this. We've got registry data for your beneficiaries. We're managing this. I can display all of that data. And the beauty is an electronic health record, you don't have to spend 3 weeks compiling it. Wonderful. Establishing a medical home. We do know that not only does Medicare have a demonstration project, but now more than 20 projects are going on around the country that have dollars tied to them for practices that are establishing a medical home for their patients. So really an electronic health record is at the cornerstone. For example, the Medicare demonstration project, you can't even be in a participant without an EHR. So we're expecting, as more and more payers tie dollars and more practices go to a medical home, an electronic health record really truly being this providing a medical home. Now, our next slide, our 5 additional value propositions: access to information from satellites, from the hospital, from the physician's home, making it much more convenient for physicians, and really promoting patient safety. From a marketing perspective, and you may really scratch your head at that, why does Elizabeth include a marketing perspective? Well, first of all, patients are looking for a technology-driven practice. We do know that more and more. You know, having a patient walk in and the stacks of records being everywhere as you walk by the doctor's office is sort of depressing, because it does leave a patient to ask, will the doctor remember everything about me? An electronic health record really says, you know what, I'm in at least the 20th century, if not, the health record really gives you the ability to generate appointment recalls. And recalls are awesome from a marketing perspective, because with an EHR we can say everybody who's due for a mammogram, Bing, bang, boom. Let's give a report for everybody who's due for a mammogram, or everybody who's due for a physical, or everyone who's due for whatever service that you feel would really, really be able to promote that patient's health care. And we go ahead and send those patients a postcard, we send them a letter, perhaps we send them a phone call that says, come on back, Ms. Woodcock, we haven't seen you for a year, we'd love to, and our records show that you were due this appointment. Potential reduction of costs. Now note that I put potential, because I have seen many practices who have taken their medical records staff and they've become scanning staff. And so certainly we know we're going to save money in terms of space, in terms of storage costs, in terms of supply costs. I mean, my gosh, the paper record system, the labels, the folders, the shelving, I could go on and on. But from a staffing perspective, I do want you to be conservative when it comes to cost savings and recognize that you may need some scanners. You may need some individuals to actually manage that record system. Now, I think what's exciting, and perhaps even the best news about this economic stimulus, this high-tech act, is now that we're going to be all in it together, I think there's going to be less situations where you walk into a practice and, 30 faxes are running because test results are pouring in and the cardiologists, et cetera, by fax because they don't have an electronic record. And so for those of you who are early adopters that feel like your head is spinning because all this paper is getting shoved into scanning and put into your EHR, I think you're really going to benefit because all the rest of the industry is going to be automated. So I think we'll truly see less scanning, the need for that, as we move to everyone having an electronic record. Now, it's very hard to recruit newly trained physicians today without an EHR because, folks, they're all used to it in their residency and fellowship programs. I mean, those academic health centers are using an electronic record, and it's very hard to step back to paper. And we do know through survey after survey that our newly trained physicians are indeed looking finally, and something you may not have thought of, but an electronic health record is actually very eco-friendly. From the perspective of, the average practice must go through, I think, an entire forest every year of trees, not just a grove, but a forest of trees with all this paper record system. And so we know Americans are looking more towards environmental friendly business. An electronic health record is an easy one for you to get there. Now, my last slide, slide number 17, I think is an important message because we do have this carrot out there, this up to $64,000 per physician. Yes, it's over a 5-year period, and yes, that additional $20,000 is really contingent on Medicaid funding. So let's call it $44,000. I think you want to have access to the funds, particularly because we've got a real challenge looming in just about 8 months. And that challenge is that we do know today, by law, Medicare reimbursement for professional fee services is set to go down in 8 months by 20.6%. Y'all, there's your $44,000 that's going to be swept up from you in 2010. On a whole nother level here, I know I'm talking about professional fee reimbursement, but I would urge you to recognize that even if Congress reverses those cuts, if for some reason there's even enough money left to give us at the end of the year, that most likely you're not going to see any gains from a Medicare perspective. And so I think having access to these funds, the economic stimulus plan, is something that you really should strive for. Next speaker, that would be great.
Thank you very much, Elizabeth, and that was a fantastic and a very timely presentation as well. I I would now like to welcome our next speaker, Jeff Chester, Vice President and General Manager at GE Healthcare. Take it away, Jeff.
Hello, everyone. And Elizabeth, thank you so much for your insight and expertise. It was very helpful in helping understand the economic stimulus package and the impact it's going to have on healthcare organizations. Thank you. And thank you to everyone on the call today. I'm honored to have the opportunity to talk to you a little bit about GE Healthcare and our Centricity solution. I've been in healthcare IT for 15 years, and the majority of that I've been a commercial leader in the revenue cycle management and electronic medical record segment. And I will tell you that this is the most exciting thing I've ever seen in healthcare IT, and I think the I have been in would agree. It's well documented that one of the biggest barriers to adoption of an EMR has been cost. And obviously this package is going to eliminate that barrier, and it's just a great opportunity for organizations who want to adopt an EMR to drive quality and efficiency to now do so. So what I want to do over the next few minutes is really three things. I want to, from a very high level, introduce you to the things that GE is focused on as it relates to our Centricity solution. I also want to introduce a financing program that we rolled out today that we think is very compelling and very complementary to the economic stimulus package. And then lastly, I'm going to share some customer quotes and success metrics, and then we'll hand it back to Russ for today with the Centricity solution, and this is in the ambulatory space. We have over 200,000 providers that touch our revenue cycle management solution and our electronic medical record every day. And we think the things that we are focused on are very well aligned with some of the stuff Elizabeth covered, where we see the market going, especially as it relates to the economic stimulus package. You know, one of those things being quality improvement. You know, there's a saying that we use in business all the time, what you can't measure, you can't improve. And we know in the paper chart world it's very inefficient and hard to measure and benchmark. With the Centricity EMR solution, we've made it very easy for our customers to measure, to benchmark themselves, not only against their peers in their group, but against every other Centricity EMR user using our MQuick solution. Not only is our MQuick solution something that allows our Centricity EMR users to benchmark themselves against everyone else, it's also only one of two CMS certified PQRI registries. So, you know, driving quality improvement is something we're very much focused on as we look at our Centricity EMR. The next is clinical adoption and accelerating clinical adoption. You know, I'm out in front of customers all the time talking to doctors and caregivers every day. And every doctor and caregiver I talk to has a very unique need, unique requirements. And they're always fearful of adopting an EMR and the impact that that's going to have on their workflow. But what we're committed to with our Centricity EMR are things like specialty content, decision support, evidence-based guidelines that drive quality of care but don't impede the doctor's workflow and allow them to continue to drive their throughput. The next thing I want to highlight is the stimulus package and where investments are being made. Connectivity and standards, interoperability are a very, very big part of it. And having information flow through the continuum of care and be available to the patient and the entire care team is critical. That's something that we're committed to. We have one of the leading HIE solutions in the marketplace today with our Centricity HIE solution. And we believe that GE is unmatched in our breadth and depth and the coverage that we have in driving standards and working with the policy organizations out there today. And the last thing I'll highlight as far as areas we're focused on and things that we're committed to is around collaboration. And we are thrilled to have 30,000 doctors using our EMR every day. And our doctors or our EMR users have set up their own independent user community. And this is a community, and also they have a very strategic and loud voice in driving our decisions around our strategic vision and what we're doing with our Centricity solutions. So that's just some highlights on the Centricity solution. We would love to have the opportunity to talk to you in more detail about that at your convenience. The next thing I want to do is transition to this exciting financing promotion that we rolled out today. And I'll just share some of the bullet points with you. Again, we'd love to talk to you in more detail about this program. But what we have done here with Healthcare Financial Services, which is an entity within GE Capital, is create a program that we think mirrors up very well with the economic stimulus package. So the basics here of how the program works is if you do an agreement with GE Healthcare and you want to leverage this program, you can acquire the software with no upfront capital outlay. And for the first 30 days, or 90 days, excuse me, of using it, you'll have no payments. For the second 90 days, you'll have a payment of either $125 or $150. And the difference is if you just acquire the EMR, it's $125 per physician. If you do our Centricity Practice solution, it's just an extra $25 per physician, and that's for 90 days. At the end of 6 months, so you've had 90 days with no payment, 90 days in the 125 or 150. So for 6 months to 36 months, you will have a payment of either $300 or $360, depending whether or not you do EMR or Centricity Practice solution. At the end of that time frame, at the end of 36 months, you have an option to either to buy down the remaining balance or refinance based on the rates at that time. And we think this is a great offering that offers flexibility, and when you are now up and demonstrating meaning exercise the remaining balance of your software solution. But something very exciting that makes it very easy to acquire the Centricity EMR. So a couple stories and quotes from our customers. This is a quote, and the three quotes I'm going to provide, one on efficiency, one on performance, and one on effective use. So the quote here you can see from Dr. Zarukian at Michigan State. And at Michigan State, they were able to decrease their provider to FTE ratio from 3.35 to 2.55 in 12 months. That's a huge metric in driving efficiency. Not only that, they were able to reduce their chart polls by 99% in the first 24 months at their internal medicine group. Great story around Christopher Crow at Village Health Partners in Texas. At Village Health Partners, they were able to increase physician compensation anywhere from $15,000 to $20,000 per doctor. And you can see in the quote that what Dr. Crow was able to do is negotiate better reimbursement rates with some of his payers because of the data, the things that he was able to show with MQuick and negotiating with his payers. And this is just one way in which the team at Village Health Partners was able to drive business performance. And then the last one here is around effective use. And we're very proud that this year 4 of the 8 HIMSS-Davies Award winners are Centricity EMR users. We are very proud of the fact that we were the first EMR certified by the National Committee for RAM. And as I mentioned earlier, Centricity EMR in our MQuick solution is one of 2 CMS certified PQRI registries, which makes it very easy for our users and customers to acquire those PQRI dollars. So in conclusion here, I just want to thank everyone for attending this event, and thank you again, Elizabeth, for your great insight and expertise. We are very passionate here at GE Healthcare about driving the quality of care and improving the efficiency in healthcare. We think we're very well aligned with our solutions, and I hope you see this financing program that we've rolled out as something that's compelling, that may help you move to your EMR investment. And we also have some very passionate customers out there that would love to share their success stories with you. So I'll now hand this back to Russ for Q&A.
Thank you very much, Jeff. And again, for more information about centricity from GE, please contact us at emr@ge.com or visit www.gehealthcare.com/high-tech-today, which is on your screen, and you can learn more about the pricing options mentioned today by Jeff. We will now move to the question and answer portion of our program, and as a reminder, the operator is here to take your live questions. So Alan, can you please instruct our audience how to register their questions?
Thank you. Ladies and gentlemen, if you'd like to register a question, please press the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. If your question has been answered and you would like to withdraw your registration, please press the 1 followed by the 3. If you're using a speakerphone, please lift your handset before entering.
Thank you, Alan. And while we wait for that first question to be registered, I have a question that I would like to ask Elizabeth. One of the questions we hear a lot of times for practices that do not have an EMR yet is that 2011 sounds like a long way away. So when do you advise that practices should start looking?
It certainly does sound like a long ways away, but for us it's actually only about 20 months. So let's break it down. Let's say the first thing that you have to do is really figure out, make a list of vendors. So you send out a request for proposal and you get your list. That's going to take you 30 to 60 days. So let's say 1 to 2 months. Then it's going to take you a good 3 months to make a decision. You're a really, really busy practice, so, just meeting as a task force once a month, that only gives you 3. You've already got 5 or 6 months gone. And then I truly believe it's going to take you a good 6 months to implement, especially if you're a multi-physician practice. Because really what you need to do, when I go back to that preserving the physician's time, is you really need to work one-on-one with physicians, particularly for physicians who may not be as comfortable with technology, who don't yet know what an iPhone is, and have never heard of Twittering, for example. So we really want that one-on-one. So 6 months may seem like a long implementation period, but I got to tell you, I want you to talk, if you think it seems long, to another practice who has implemented, and I can bet theirs was probably 6 months, if not longer. So now we've got 9 to 10 months, and that means we have less than 12 months, in fact, right about 9 months, to actually figure out what the economic stimulus package has told us to do to be a meaningful user. How do we report that? How do we, for example, submit information on selected quality measures? No, we got to do it. How do we do it? And I think you need some time. What I don't want you to do is to get to, November 15th of next year of 2010 and say, oh my gosh, we've got 45 days to figure out how to report this stuff. I want you to give yourself some time. So I guess when I back down, Russ, I'm thinking you got to start sometime in the next 30 to 60 days in order to give yourself a good 6 months to figure out how to really embrace this in your practice.
Well, great. Thanks very much, Elizabeth. And now I would like to go to the phone for our first question. So, Alan?
Line of Brian Graybrow. Please proceed with your question.
Hello. Hello, this is Brian Graybrow from the NYU Langone Medical Center Faculty Group Practice. Thank you very much for your call, and we wanted to find out whether or not the timeline is really 2011 or if it begins on 2012.
Elizabeth, I think that's a great question for you.
Right. Well, as we understand it, it really does begin on 2011, although as I understand, the funding then begins in the following year. So I think that is a really good question. So we don't expect to receive the checks on January 1st, 2011. So thank you very much for pointing that out. But in order to receive the full funding, again, what we know from the Act, EHR, and be a meaningful user in 2011.
Is there a cutoff time for that?
Well, at this point, that's a great question. That's one of our unknowns. Is it January 1st? Are we going to are we going to get half of that first year payout, which was the $18,000 if you join on July 1st? What if it takes you time to report it? That we don't know. And we don't know the specifics of when you're actually going to get that money. I mean, we go back to, for example, a lot of the failures of PQRI. Many of you are still waiting for the checks that haven't come from last year, and some of you from even the previous year. So I think it is a good point. We won't see the check on January 1st, 2011, but we don't know the specifics of the question that you're asking.
Thank you. And are radiologists freestanding also?
Sure. That is a great question, and I pulled the specifics, and I will tell you it's on page 355 of the Act, because I felt for sure someone would ask about hospital-based eligible professional. And specifically what the Act says is term hospital-based eligible professional means with respect to covered professional services furnished by an eligible professional during the EHR reporting period for a payment year. An eligible professional such as, and it points out, pathologist, anesthesiologist, or emergency physician. And so radiologist, as you noted, is not in there. So they did specifically point out pathology, anesthesiology, and emergency medicine. I would note, for those callers who are questioning what does this mean, is there is an exemption that hospital-based physicians will not, I repeat, will not receive this financing, will not receive these stimulus dollars. And, I personally, it's my opinion that this is a real tragedy of the Act, and, but we do not know the specifics other than what I just read. I would, because there's some more verbiage, I would ask that you do take a look at page 355 to get some more specifics about hospital-based eligible professionals. And I will say I do know that the specialty societies representing hospital-based physicians are madly working today, as they were from the moment this was made public, to really try to have those exemptions reconsidered.
So, Alan, do we have another question?
Yes, we do. Our next question comes from the line of Dave Capuano. Please proceed with your question.
Yes, hi. This is St. Luke's Physician Group in Bethlehem, Pennsylvania. And Elizabeth, we were a bit confused as we watched the slides and listened to you telling us about the various parts of the payments. In 2010, one of your last slides, it says as of January 2010, we were looking at a potential for a 20.6% decrease in reimbursement. Can you explain that? Because that sort of argued with the previous information.
Sure, that's a great question. And it really actually has nothing to do with the economic stimulus package at all. The slide on the source-based relative value scale and Medicare Part B payments for physicians for professional fee services. Every year, there is a lot of back and forth about what will the Medicare payment rate be for physicians. And we have this conversion factor, we have this relative value unit scale, and every year, like last year we heard, oh my gosh, it's going to be a 10.5% payment cut. And really it's all because of this crazy flawed formula that physicians are paid by. And this crazy flawed formula, every year for the past 5 or 6 years, at the very last minute, Congress has stepped in and say, oh, we love our doctors, let's give them no increase. But let's give them maybe a little tiny bit of an increase. But let's certainly not have the payment cuts that are scheduled by law. And what the challenge is that if you recall last July, right before really the recession hit, Congress stepped in and say, oh, good doctors of the world, we are going to give you a little bit of an increase for the rest of 2008 and all of 2009. But that's all they said. They didn't say for the next 15 years. They didn't even say for the next 2 years. And so what we do know is the RVRVS, the Medicare payments to you, to your physicians, are scheduled by law to decrease again significantly in 2010. And so my point is, you know, if you're kind of blowing off this economic stimulus package money, I would suggest that you rethink it, because we are going to likely see some sort of payment cuts. I hope it's not going to be 20%, but we're going to see some payment cuts in 2010. And my point was, be in a position to get some of this economic stimulus package money, because otherwise you're really going to be in a double whammy here. Not only with Medicare reimbursement cuts, again, by law scheduled 20% decreases 2010, but if you're not in a position to capture that economic stimulus package money, that's also going to be further money that's going to be left on the table. So really two different points, but be on the lookout, really take some legislative actions to try to get those payment cuts reversed again this year.
Thank
you. Thank you. And I would like to once again thank Elizabeth and Jeff for their presentations today. For additional information or to contact GE about the economic stimulus package, please go to gehealthcare.com/hightech. The address is shown here on your screen, and you will be done and bookmark the site. We will be updating that resource frequently, so please check back for the latest information on the economic stimulus plan and the evolving healthcare IT landscape. This does conclude today's program. Thank you again for joining us today, and goodbye.